Good evening, everyone. I'm here to welcome you to Red Wine and Yoga Pants. My name is Ellen Sharp. I'm the Director of Physician and Outreach Marketing for Franciscan Health. Thank you all for coming this evening. We always like to bring programming for women that's both educational and fun. And so I want to ask you, do you leak when you laugh? Do you? We have just the man here to help you out with that. We have Dr. Mark Cabelin. He is board certified in both urology and female pelvic reconstructive surgery. So please welcome Dr. Mark Cabelin.
Well, good evening. Just want to welcome you again to this event put on by Franciscan Physician Network and Franciscan Alliance. And thanks to Briar Ridge for putting out this outstanding event. Thank you for all the organizers. But mostly thank you for all coming here to learn about something that I have spent a long time doing and taking care of patients just like you. So without further ado, I'll just go ahead and start with our presentation. So our topic today is urinary incontinence. And this is a broad spectrum disorder encompassing pelvic floor disorders. So a little bit about me first. So I'm fellowship trained in female pelvic medicine. I did special board certification. I had to turn in a list of case list to sit for the boards, and I'm very proud of being certified in this. I also did a fellowship in female pelvic medicine and reconstructive urology in New York at Columbia and Cornell. And I have 18 years of experience dealing with female urology and conditions of men and women. So in terms of pelvic floor disorders, one of the conditions that we often talk about is urinary incontinence, and there are many associated symptoms associated with urinary incontinence, and we'll talk about that. In addition to that, there are a lot of voiding dysfunctions that affect both men and women that we'll talk about, not just urinary incontinence. And finally, we'll talk a little bit about pelvic organ prolapse. Now, what I'd like to do is educate you on the what, the when, the why, and the how of urinary incontinence and pelvic floor disorders. So the what would be sort of what are the symptoms that you're experiencing that are troublesome. There are a lot of symptoms that you have that you don't think are troublesome because of culture, because you think it's related to aging, and because you just think you shouldn't have treatment for it or that there are no treatments. The when would be the conditions that you have, the urinary symptoms that you have as related to the condition that we want to diagnose you with. The why would be the actual diagnosis and the anatomical and functional disorders that cause your symptoms. And the how would be the treatments that we're going to offer you. So these are the things I'm going to try to answer for you today. So again, the symptoms that we're going to talk about include what you will look at yourself or your friends and see whether they affect you and whether they need treatment. So that's the you. The I part will be the diagnosis, and the we part would be the shared decision making we do in order to come to a good treatment plan that is appropriate for you. So how do we go about diagnosing these pelvic floor conditions? We obviously need to do a very thorough history. So we'll spend a lot of time in the office going over all your symptoms. We use questionnaires, and these are questionnaires that we use for scientific studies. And I use that for assessing and grading your symptoms. We also do a complete pelvic exam with grading systems that help me understand exactly how prolapsed you might be or what kind of anatomical abnormalities you have. And then finally, diagnostic testing is something that we focus on. So some of the urinary symptoms that you might have include irritative symptoms. And so these symptoms include frequency. This is something you probably know very commonly. Frequency is something like urinating every 2 hours or every half hour or even every 10 minutes. And we're talking about urinary symptoms really not related to urinary tract infections. Another common symptom is urgency. So you've got to go, you got to run to the toilet. And finally, nocturia. So nocturia is urinating at night And I would define that as urinating 2 or more times at night. And when you're urinating 2 or more times at night, you are urinating basically every 4 hours or less. And when you urinate with the criteria of every 4 hours or less, you end up having significant effects on your health. That really disrupts your REM sleep. So nocturia 2 or more times a night is something that I think we think of as acceptable at our age or as we get older, but really has significant impact on your health. Now, there are other urinary symptoms that we classify as obstructive. So for instance, slow urinary stream. It's kind of weak and it takes a long time to urinate. A weak urinary stream, incomplete bladder emptying. So these are symptoms that you shouldn't, I don't think, accept at your age or even as you get older, and they may cause problems and pathology in the future. And then intermittent stream, so a stop and go stream. These are symptoms that you might experience with perhaps your husband, with men with prostate disorders and enlarged prostate, they often have an intermittent stream. But for women, an intermittent stream is also not a good thing. And then urinary hesitancy, which is the pause or prolonged pause that you have when you start your stream. And then finally, post-void dribbling. So if you have any of these symptoms are worth evaluating more fully. Now, just to go over a little bit about your urinary tract, for some people that they may not be very familiar with the anatomical terms, but basically in the urinary tract you have 2 kidneys that drain into ureters, which are tubes that drain urine into the bladder. The bladder is a solitary organ. It sits near the uterus and it expels urine down a urethra and out, basically out of your vagina. And here you can see some of the anatomical relations. Here's a side view of the female pelvis, which includes the pelvic bone, the bladder, the uterus, and the rectum. These are the organs that sit in the pelvis. Here's a description on the right panel of the pelvic floor. What you see in red are basically the muscles of the pelvic floor, and they surround both the rectum and the vagina and the urethra. They actually form a bowl, and we often call that the pelvic basin or pelvic diaphragm. So let's talk a little bit about urinary incontinence. So the most common thing, and the focus of this event, is urinary incontinence related to stress or coughing, laughing, or sneezing, or exercise. So what you have is you have increased abdominal pressure, causing the bladder to be pushed into the pelvis with urinary leakage. There are other types of incontinence, of course, is urgency incontinence. Urgency incontinence would be a strong urge that comes earlier on before bladder filling, and then you have leakage. And that's very different from stress urinary incontinence. And another form of incontinence is retention or overflow incontinence, where the urethral closure pressure is overwhelmed and incontinence occurs after the bladder is completely full. So there are other types of incontinence, including neurogenic bladder, and neurogenic bladder should be suspected if you have any of these conditions: stroke, Parkinson's disease, multiple sclerosis, Alzheimer's, diabetes, or any spinal cord injuries. So even diabetes, if you had diabetes for a long time, or have advanced diabetes, or have peripheral neuropathy or other side effects from diabetes, you can have a diabetic bladder, and we call that diabetic cystopathy. And that can present with either frequency, urgency, overactive bladder symptoms, or even retention. So you could have both obstructive or irritative urinary symptoms. So here's a common term. Who's heard this term, overactive bladder? Can you raise your hand? Anyone? Okay. So overactive bladder is basically a symptom complex including urgency, where you have to rush to the toilet, and you may or may not make it to the toilet, but you feel like you're rushing to the toilet all the time and very early on before your bladder is full. So the spectrum of overactive bladder includes urgency, frequency, nocturia, and urgency incontinence. And so if you have any or some of these symptoms, you have overactive bladder. It's one of the most common conditions that women experience nowadays. The other conditions I wanted to talk about briefly include pelvic floor disorders or pelvic organ prolapse. So cystocele is a bulge into the bladder. A uterine prolapse is the uterus bulging into the vaginal canal or outside of your body. And a rectocele is a bulge of the posterior vaginal wall sticking into the vagina. And these are all pelvic floor disorders. And we broadly talk of it as pelvic organ prolapse. So a common term may be called the fallen bladder, where you get a bladder tuck, and this is what we call a cystocele. So here in the left panel you can see the bladder with urine in it. It's yellow, falling out of the pelvis. So that's a cystocele. Here in the right panel you can see that we have, this is a cystogram. So your bladder is usually a globular shape, and in this cystogram you see that it's dumbbell shaped. So that's the bladder, or part of the bladder, falling out of your pelvis and out of your body. And then here is a depiction of uterine prolapse, where the uterus is falling out partially or completely. Just to ask, how many people know people who've had uterine prolapse? Anyone? How about cystocele or bladder prolapse? And rectal prolapse or rectocele? Okay, so it's pretty common. Here's a picture of the rectocele. The rectum bulging in the posterior vaginal wall. And these can cause symptoms of splinting or pushing on your posterior vaginal wall in order to help defecate. Pressure, impaired emptying of the colon or your stool. Those are some of the symptoms of rectocele. Some of the symptoms of cystocele include difficult emptying, slow stream, weak stream, some of those irritative symptoms that I mentioned. And they also can cause frequency and urgency. They can cause complete urinary retention and even bladder or kidney failure. So let's move on to some diagnostic testing. So here is a picture of a man and a woman urinating into a uroflowmetry meter. So this is how we measure urine flow by urinating into this container, which is, and the flow rate is measured by the measuring device below. So we do this in the office, and this is one of the easiest diagnostic tests that we can use to figure out what's going on with your voiding disorders. So here's a little schematic on the left, which shows the flow rate on the y-axis, and on the x-axis the time. So you can see that it's sort of like a bell-shaped curve where you have a peak in the middle of your void, and then it slows down afterwards and decreases. And what we do is we measure the flow time, the maximum flow, and the average flow. On the right panel, we have a picture on the left upper corner of a very strong flow. So this would be typical of very young men or women, where they void very quickly and they have a high peak urinary flow. My flow used to be like this at one point. On the right panel, we have a picture of a flow that's, you can see, is a little bit more prolonged, and it has some peaks and valleys, and that might be an obstructed flow or flow related to a weak bladder, or again, anatomical obstruction. In the left lower corner, with the 3 humps, that's an example of a bladder that is probably weakening with time, and that may be related to diabetes, obstruction of the prostate, aging, and other conditions. And the panel on the right is a very right lower quadrant. There is pretty typical of prostatic obstruction in men, but also may be seen in aging women or in obstruction. More sophisticated testing would include urodynamics testing, and we do this in the office. Basically, in our cysto or urodynamic suite, we have some software and we have a computer, and we have a sophisticated chair that can lift patients up, and we can also do C-arm or X-ray evaluation, which you see in the right panel. So this is an example of some of the reports that we can generate from urodynamics, including the X-ray picture on the left called a cystogram, showing, in this, I don't know if you can make it out, but it's spherical, it's globular, which is normal for a bladder, but there's some irregularity to the lateral wall in the inferior wall, and that's abnormal. That can be very suggestive of obstruction. On the right side, you can see the pressure transducer, which measures the time and the pressure of certain parts of the bladder, whether it be abdominal pressure, bladder pressure, or the flow rates. And with all this testing, we can really make a concrete diagnosis of your condition. Finally, let's move to therapeutic interventions. So a lot of the things that you have, you just accommodate pretty much by your own personal lifestyle changes. So you might say, you might reduce your caffeine intake, you might reduce alcoholic intake, you might reduce your fluid intake, and these are adaptive things that you do before you even see your doctor. The other therapeutic interventions we'll talk about include medications, treatments, procedures, and surgeries. So here, under lifestyle changes, so one of your lifestyle changes might actually be I'm growing old and it's okay. And that may or may not be appropriate. You may have a condition that's very treatable, easily, and curable. But most people that come to my office pretty much say, you know, I think I'm growing old and urinating 5 times a night is okay. And that's clearly something that you can fix. So wearing pads is something that you do, and that's a good sign to us that you need treatment and you're curable and you're treatable. So a lot of patients, I think that that's okay, and it's part of growing old to wear 1 or 2 or 3 pads a night. It may be true, but it's not something that you have to live with. It's something we can treat. Other people may avoid exercise altogether, and that obviously has health conditions that, you know, aren't really acceptable. We would like to cure you of stress incontinence and get you back running or doing any physical activities that you like to do. And finally, people do a lot of bathroom mapping. They really need to know where every bathroom is, you know, whenever they go, or they just stay at home. And these are things that I think, you know, is a shame that people do just to accommodate their incontinence. So some of the things we can offer obviously include medications. There are several classes of medications, including anticholinergics, something we call M3 receptor agonists, and also other alternative bladder relaxants. We also have medications and sprays that can affect your fluid volume, and that's primarily for nocturia. Nasal sprays. Of the medications that affect bladder function, these include anticholinergics. You may use some of these already, and they're quite effective. An M3 receptor agonist called mirabegron is often used. We can use it in combination with the first medication. And for really difficult to treat patients, we can add a third agent, such as a bladder relaxant. A fourth medication can be used to help contract the bladder for weakly contractile bladders, and that's bethanechol or urocholine. We do use some medications that your husband or men use, such as tamsulosin. We do use that for women as well, and this helps with their emptying. It affects their external sphincter. A medication that is used in Europe called duloxetine is not approved in the United States, but it has shown has shown to be the only medication that has some effect on stress urinary incontinence. And again, to decrease your fluid at night, we have pills or nasal sprays. Now, just to go over the pelvic floor one more time, the pelvic diaphragm or pelvic floor or pelvic basin is a constellation of muscles in your pelvic musculature that are attached to your pelvic bones with ligaments. Here's an inside view on the right panel, which shows that the pelvic floors surround the rectum and the vagina and the urethra. So one of the treatments that we can offer, that Franciscan can offer, includes pelvic floor muscle training or physical therapy or pelvic floor rehabilitation. Something that you can do, or you may be doing already, includes Kegel exercises or squeezing your pelvic muscles on your own. And I often prescribe patients to do that for 10-second holds 10 times in a row, 3 times a day. So these Kegel exercises you're probably familiar with. You can do them on your own. A lot of patients have tried them before they've come to see me and have failed. Who here does Kegel exercises right now? Okay. Okay, here's another treatment. You guys are probably familiar, Botox for your wrinkles, I guess, in your forehead. Botox can be used in the bladder. I don't know if you're very familiar with that or not, but Botox is very successful in relaxing the bladder muscle in overactive bladder syndromes. Here is a depiction of a doctor doing this in the OR perhaps, or in the office, where you inject about 100 units or 200 units into the bladder musculature at multiple spots. This can be done with local anesthesia, general anesthesia, or sedation. Here's an endoscopic view of the needle going into the bladder musculature with the cystoscope on the right lower panel and multiple spots injected into the bladder. It's a very quick procedure. It's very effective. We use it often for people who medications don't work. So another treatment option is called tibial nerve stimulation or posterior tibial nerve stimulation. The posterior tibial nerve, which runs on the medial aspect of your ankle or your foot, and it runs up the back of your leg, and it goes back to your bladder. So we found that if you stimulate your posterior tibial nerve, as you can see in the right panel here, with a small needle, 30 minutes once a week for like 6 weeks or 12 weeks, you have a significant improvement of your overactive bladder symptoms. So you can avoid surgery, you can avoid medications, and you can get nerve or neurostimulation to the bladder, and this works. So that's posterior tibial nerve stimulation. This we can do in the comfort of our office. You can't do it at home. And a new development is transcutaneous posterior tibial nerve stimulation. So no needle, but just patches placed near the posterior tibial nerve, stimulating the posterior tibial nerve and backfeeding back to the bladder and causing the overactive bladder to relax. It reduces frequency, urgency, and urgency incontinence, and reduces your pad counts. This is another cool device called InterStim, or sacral neuromodulation. It is a form of neuromodulation. It's a permanent form of neuromodulation. Here you have a picture of the battery, which is right next to a quarter. It's very small, as you can see. It's not a big procedure. It's a very quick and effective procedure. We also use this InterStim device for patients who can't urinate, who have non-obstructive urinary retention. We use it for patients who obviously have overactive bladder symptoms that don't respond to medications. We use it also for patients who have fecal incontinence or defecation disorders. They have difficult emptying their bowel or their bladder. On the right panel here, you see that we place the battery on the right or left side of their lower or upper buttock. It's not in the back, it's not back surgery. And it's a small incision that we make. So it's an electrode that goes to the S3 nerve, which causes a neurostimulation on the nerves and centers that are responsible for bladder function. And this is very, very effective. Here's a picture of interstim sacral nerve stimulation, the incision that is in your upper buttock. You don't feel it, it's underneath your skin, your fat pad. It's a quick procedure that can be done. So just to move to what we're talking about here today, stress urinary incontinence. So this is the condition of urinary incontinence from coughing, laughing, sneezing, jumping, exercise, activities, standing up, sitting down, things like that. So this is one of the most common disorders that urologists and we treat. And in the right panel, there's an example or schematic of the mechanism of stress urinary incontinence. So why does stress urinary incontinence occur? It occurs because there's an increase in abdominal pressure that pushes onto the bladder with equal transmission to the external sphincter. And because when you cough or sneeze in incontinent women, you have this equal transmission, you don't have leakage. So what happens in stress incontinence is that your urethral ligaments are weak and your bladder and urethra fall out of the retropubic space, and in incontinent women with stress incontinence, they have unequal transmission of pressure to their bladder and not to their external sphincter. And again, this is because of weak ligaments. So what is the cure of stress incontinence? So here's a frontal cut view of your urethra or pelvic floor. So you have your urethra, the tube there in the middle. You have your urethral pelvic ligaments that extend from the urethra to the lateral border of your pelvis. And this is all underneath your intervaginal wall. So when your urethral pelvic ligaments are weak, your urethra descends into the vagina when you cough, laugh, or sneeze, and then you have leakage. In the right panel, there's a depiction of the urethral pelvic ligaments in pink, as you can see, but also the pubourethral ligaments. So the pubourethral ligaments are additionally responsible for stress continent or keeping yourself dry during coughing, laughing, or sneezing. So if the pubourethral ligaments are weakened with childbirth, aging, or other conditions, you develop stress incontinence. On the right side, you see an MRI view, magnetic resonance imaging view of the urethropelvic ligaments and the pubourethral ligaments. So if this is the cause of stress incontinence, what is the cure of stress incontinence? And that's where we go to slings. So these are meshes, vaginal meshes, or vaginal tapes. They were originally called tapes. And as you can see, they're very thin, and they can be long or medium long or very short. And these reconstruct the urethropelvic ligaments or the pubourethral ligaments. So for weakened ligaments, we replace the ligaments with synthetic mesh, and this is the mechanism of cure of stress incontinence. If we don't have to only use synthetic mesh, we can also use your own tissues. We can use cadaveric tissues called fascial tissues, or your own tissues called autologous tissues. So we could harvest your fascia lata, which is the lateral thigh fascia or strong tissues. We can also use your rectus muscle fascia right below your belly button. We can harvest these and use your own tissues to form a sling. And this was the original slings that were created 20 years ago. And we can place them in a retropubic position, as you can see in the right panel, in a U-shaped. And this is a very good way to treat failures from synthetic slings. So in my next slide, we have what started it all. Ethicon made the TVT, or tension-free vaginal tape. Has anyone ever heard of this sling, TVT, or ever had it done? You can say that if you like. But this started it all. This was a revolution in treatment of stress urinary incontinence. It was a synthetic mid-urethral tape that was placed underneath the urethra and came behind the retropubic bone, just above your pubic bone. It could be placed in like 30 minutes, and it had high success rates, about 95 success rates for cure for stress incontinence. As you can see in the right panel there, you can see how it's placed in a U-shaped configuration. So that was the first sling. It was around for a while until we developed our second generation sling, which are obturator slings. So bright surgeons figured out that, hey, we don't have to put it through the pubic bone where there might be some blood vessels. Let's put it through the obturator space. The obturator space is that space in your pelvis on each side that transmits musculature. So that's your obturator foramen, or an opening in your pelvic bones, and that's where the tape goes. And it ends up being placed in a less invasive fashion with lower risks. And there's, on the right side, a side view of an obturator placed sling, mid-urethral sling. Our third generation of slings came out recently, and they're called single incision slings. So one incision, not three. And this is an example of single incision slings. So there are multiple companies that offer this sling. But you can use a 1.5 centimeter incision to place a sling. The procedure can be done in 30 minutes. We can do it under general anesthesia. Some people do it under local with sedation. But success rates for these mini slings are almost as good as the traditional slings. So I would say that most surgeons now probably move to mini slings. And because there's less mesh placed, you have much less or fewer complications. So let's say you fail a sling, or you just don't want a sling. You can do something called bulking. Bulking, however, is not as successful as traditional slings, which I told you have about 95% success rates. So bulking is a urethral placed or periurethral placed material that push the urethra together. And it can be placed very easily with local or sedation, and can be placed in probably 15 minutes or so. Here's another example of bulking with an endoscopic view on the right. You can see that the urethra on the right there is pushed together. That black space is the urethra looking into the bladder. On the left panel, you see that the bulking material is placed at the bladder neck. So basically, we talked today about urinary symptoms. We talked about obstructive and irritative urinary symptoms. We talked about a lot of conditions, including incontinence and pelvic prolapse, overactive bladder, neurogenic bladder, the types of incontinence and conditions. We talked about a lot of the medications that are available, a lot of the treatments that are available, non-invasive, and we talked about some of the surgeries that we can offer for treatment of urinary symptoms. So I'd like to end here, and I want to thank you again for coming to this presentation. Again, thank you for coming and enjoying your evening here, talking to me about these conditions.